Himanshi, there are some people waiting. I think you have to let them in. Hello. Yes, Himanshi.
Hi, good evening, Dr. Ibrar, sir.
Namaskar, sir. Good evening.
Anand, just look at the participants list, whether Dr. Sanjay Jain, the SI president, I am also looking.
Yes, I will check, sir.
Just check.
इसमें तो हम दोनों बात नहीं है.
Dr. Sanjay, if you are there, could you please come in?
I don't think he's there.
There is one Sanjaya, but I am not sure whether it is him. Dr. Sanjay Jain. And Dr. Prabal Niyogi is there. Dr. Niyogi, can you please come in? Dr. Niyogi is the president-elect of ASI from Allahabad. Dr. Shabir's colleague.
Good evening.
If Dr. Sanjay Jain is not able to join in time, I will request you to say a few words.
Right. Good evening, Dr. Kapoor, and good evening.
Just a minute. Just 1 minute.
Yes, sir.
So I think it's 7. We can start. Anand, ready? Himanshi, ready?
Yeah. Yes, sir.
Okay. Good evening, everyone. Welcome to the second edition of a new activity launched by the Jaipur Surgical Tutorial, which is being looked after by my colleague, Dr. Anand Nagar. Anand, you can come in. I'm VK Kapoor from Mahatma Gandhi Medical College and Hospital in Jaipur. And this is an online educational portal which we started about 2.5 years ago. We conduct a weekly session on every Saturday morning, 9 to 10. It was primarily started for the MCH and DNB students in surgical gastroenterology, but all the topics are obviously of interest to MS and DNB students in general surgery also. And I'm sure many of our student members are actually MS and DNB general surgery students. And as I mentioned, that this activity is coordinated by my colleague, Dr. Anand Nagar. In between, I will keep sending you, keep posting his number. So those of you who want to join Jaipur Surgical Tutorial, please feel free to WhatsApp him. Just send a message to him. He will add you to the group and you will get all the notifications. In addition to that Saturday morning activity, we thought that we would start an evening activity also, which is at the moment once in a month. We did the first activity last month, where we did a master class on living donor liver transplant. The format of the master class is that we do 2 sessions on 2 consecutive days, the last Thursday and Friday of a month, 7 to 9 p.m., and try to cover a topic. So last week we had a galaxy of speakers from all over the country, and actually almost all of them, I must say, were my alumni from SGPGIMS who are now doing living donor liver transplant. And this week we chose a topic which is of interest to not only GI and FPB surgeons, but general surgeons also, which is safe cholecystectomy. And again, we have a galaxy of experts. And actually, this topic was suggested by my former colleague from SGPGI, who's now at Sakra Hospital in Bangalore, Dr. Sadiq Sikora, who's an authority, besides on so many other things, on safe cholecystectomy. And we share this passion. We also have Ibrar and Dr. Vishal Gupta, who've done a great service to the cause of making cholecystectomy safe in terms of not only lectures, book chapters, publications, but even books, which they have all written. So today's activity actually is a brainchild of Dr. Sadiq. So I would request him to moderate most of the sessions. I'll keep making some comments in between. And because it is an activity which is of interest to general surgeons, I made a request to Dr. Sanjay Jain, who's the president of ASI, and to Dr. Prabal Niyogi, who's the president-elect. Dr. Niyogi, I think Dr. Sanjay Jain has not been able to join, but Dr. Niyogi is there. He's currently at the MLN Medical College, Allahabad. And one of, again, my former students, Dr. Shabi, is a friend and colleague of Dr. Niyogi. So before we start the masterclass, I'll request Dr. Niyogi on behalf of ASI to just say a few words and formally inaugurate the masterclass. Dr. Niyogi, please.
Good evening, Dr. Kapoor. Good evening, teachers and delegates. At the outset, I would like to my thanks to Dr. V.K. Kapoor and to the Jaipur Surgical Tutorial to involve ASI in this very important tutorials that you are conducting. This masterclass. You teachers here, I can see you're all teachers of teachers. We're taught by people like V.K. Kapoor and Dr. Sadiq Sikora. They are an authority on this subject, and it is so nice to see you all here on board. Of course, today we've chosen a topic which is of interest not only to GI surgeons but also to general surgeons. The idea is the prevalence of injuries in Napoli is still about 2 in 1,000, which is still a lot, I feel, because we feel that a patient of a gallbladder just walks into your clinic, a happy patient walks into your clinic, and he goes out in a month or a couple of months as a biliary cripple, which is absolutely unforgivable. So, like, this is something that we have to take it to heart, and there are so many methods, as both, I'm sure, Dr. Sadiq, who's an expert on biliary injuries and biliary strictures, his work, Kapoor's work, we know them from close angles, being living in the same state of Uttar Pradesh, where Sadiq Sikora's was his Karma Bhumi, and of course he's deserted us and gone down south, but we still remember him as a great teacher, Dr. Kapoor and Dr. Sikora both. So without much ado and without wasting too much time, we would like to ask Dr. V.K. Kapoor to take it over from here. We would like to, before I finish, request to the Jaipur Surgical Tutorials that we would be happy to get ourselves as the ASI to get involved in such academic activity. I am the president-elect, which I will be taking over next year as the president of the association, and I would need all your support.
I think we lost Dr. Niyogi's connection, but I would like to thank him and ASI. And with that, we will start the masterclass. The first presentation is by Sadiq. I will take the liberty of introducing the first chairperson and speaker, because they are my colleagues, current colleagues. So the chairperson for the first session is Major General Dr. R.P. Chaube, who is one of the senior most GI surgeons from the Armed Forces Medical Services. After serving the army, He joined the Andaman Institute, National Institute of Medical Sciences as its director. And after that, he joined Mahatma Gandhi Medical College Hospital even before I came here. And it was under his leadership that the MCH course in surgical gastroenterology started at the Mahatma Gandhi Medical College and Hospital. And even after his official superannuation, he continued as the emeritus professor in the department. And the speaker again is, everyone please mute yourself. The speaker is Dr. Ajay Sharma, who is now my colleague and the head of the Department of Surgical Gastroenterology at my new institution. He is from SGBGI. He's one of the pioneer GI surgeons, not only in the city of Jaipur, but in the state of Rajasthan. So I would request Ajay to start his talk on evaluation of a patient with the gallstone disease. And over to Dr. Chaube and Dr. Sadiq. Ajay, please start.
Thank you, Dr. Kapoor, sir, and special thanks to Dr. Sadiq, sir, for starting this initiative. It's a very much required topic present date, and I think I hope I'm able. My intention for the presentation made today was to mainly serve MCH students and the practicing general surgeons. So it will have a lot of practical knowledge, and the theoretical aspect will be slightly less. So with that. Okay, so the topic given to me is evaluation of lab tole. If I start with history of a patient whom we need to examine, the points are very straightforward and clear, that the pain abdomen, site, the duration. But I think most of these points, if I tell to most of my residents and even the MBBS students, they will be able to tell more better than what I will be speaking. That what is it relation to the food in the patient of gallstones? It is more related to food. And it is always important what is the last episode of pain. A patient who has had a pain a day back, patient who is having a persisting pain, patient who had a pain few months back makes a difference in your surgical planning for the patient. How severe the pain is. Is it associated with fever? Is it associated with severe tenderness in that area? The patient is having shoulder pain. The classical pain is never in the right hypochondrium. It can be anywhere in the abdomen, but most common side being right hypochondrium. But understand, right shoulder, back, these are the areas which may have a referred pain also. Sometimes you may have patients which may have no history of pain. These may be, but they have gallstones. They will be categorized in the category of asymptomatic gallstones or incidentally detected gallstones. Most of them are young pregnant females who have got sonography for their pregnancy and found them to have gallstones. So they may be asymptomatic. Then second thing is dyspeptic symptoms. They may not be pain, but the patients can have a symptom. These will be included in symptomatic gallstones. And this has to be typically qualitative dyspepsia. That is, a patient is having dyspepsia with a fatty food. Sorry. Then, of course, any patient of gallstone, I was being taught when I was a resident that jaundice, pancreatitis, history of cholangitis, these are important. So the patient who is having jaundice has to be more relevantly taken in this group of patients, whether he is having pigmented urine, acholic stools, that is features of obstructive jaundice. For residents, I think the pruritus, acholic stools, and pigmented urine are the characteristic features of obstructive jaundice. And waxing and waning of jaundice may be present in some of this group of patients who have a stone passing into the CBD. A fever, which may be present, which is very important, even if he has a history of stone with cholecystitis, or the patient is having cholangitis or pancreatitis. All the three becomes an important relevant history in this group of patients. Always take a history whether the patient was admitted, especially for pain, jaundice, or fever, or pancreatitis, as I have already told. With a gallstone, always keep it relevant that anorexia and weight loss are important, because many of the patients in India can have gallstones with malignancy along with that, which needs to be excluded based on evaluation subsequently. How long has been the pain? What intervention relieved how long has been the jaundice, and what intervention relieved the jaundice? And was any procedure done in the past for any of the surgeries done in the past? The medical diseases are very important in this group of patients. I have found that the general surgery department often overriding the findings that the patient tells that he has had a history of GI bleed, he has a history of ascites, he has a chronic liver disease, is chronic alcoholic. Take it into consideration because the surgery is going to be difficult if you do in this group of the patients. Any patient with bleeding disorders, that is for all laparoscopic procedures, you have to be very cautious. Rather, with most of the surgeries nowadays, at least the closed space surgeries, that if he is on anticoagulants. Previous surgeries, whether the patient had a post-operative course, how was it? How long back the surgery was done. A surgery was done with a fan and steel incision has less relevance. Difficult wound healing with a right subcostal incision, definitely you have to be more cautious. A midline incision, poor wound healing, secondary intention of wound healing. I think take it cautiously because you may find it difficult to do a lap chole in this group. Scars which are close to umbilicus or right hypochondrium or midline are always to be taken consideration of vis-a-vis if a patient is having a left side scar or the patient is having a fan and steel incision, that may be relevant but not that relevant as for this for lap chole. These are the routine investigation, routine things that we always ask because cardiac disease, antihypertensive medications, pulmonary psychiatric disorders, and long-term anticoagulation is very important. A tender lump, take it cautiously. Palpable spleen, very important. Take it cautiously again. This may be a underlying EHPV or a portal hypertension or a CLD patient. Icterus, be cautious. Many times we get a patient who have a written performer from periphery. The patient is having gallstone related jaundice. Gallstones never cause jaundice until unless it is a Mirizzi syndrome or it is a stone slipped into the CBD. And always auscultate the lung because air entry at the bases may signify that the patient had a ruptured gallbladder or a pancreatitis, decreased air entry into the left base, a subtle marker of pancreatitis that he should be cautious of. Let's come directly to the investigations now. These are routine investigations that we do for any fitness, that is a CBC, we do a LFT, INR, and definitely creatine, chest X-ray, and blah, blah, blah. But with LFT, I mentioned GGT. So that's what is the importance of these investigations. I think LFT and TLC are very important investigations. If the patient is having high TLC, be cautious. He's having some infection somewhere or an acute inflammation. Bilirubin, you will find always it is mentioned the bilirubin is so much. They may not have a written report of how much was total or direct. That will give you evidence of direct hyperbilirubinemia. SG, AOT, PT, AST, ALT are very relevant factors because they inform the inflammation of the intrahepatic inflammation of the biliary tree. Implies that you should be cautious if the patient is having a significantly high OTPT. Alkaline phosphatase is a marker of obstruction of the CBD. There is a stone in the CBD or any other cause of obstruction. So increased alkaline phosphatase, you have to be cautious. Don't take it lightly. Same thing with GGT. I have mentioned in the lower part of the slide that GGT is very important because it increases in the hepatobiliary dysfunction, especially cholestasis, that the GGT is increased. As compared to alkaline phosphatase, these levels do not increase from the other sources. GGT is primary sources level. Of course, PTINR, which is very often not considered to be a part of LFT in the reports, be cautious that you should get a PTINR. If the patient is having high INR, we have to be again worried about any liver disease that is there. You have to see whether the patient is having jaundice, is having obstructive jaundice, the pattern of bilirubin showing a non-obstructive pattern. Patient is showing hepatitis, that is increased OTPT with a normal bilirubin. Patient is having acute or chronic liver disease. These will alarm you for your procedure. How to diagnose now? That on the primary investigations, important thing is sonography, which is almost 95 to 98% can pick up. It has a sensitivity of 95 to 98%. Always ask these few questions to your radiologist. Ask him about the gallbladder wall thickness, whether the gallbladder wall thickness is uniform or non-uniform. If he can identify any ischemic area in the wall, if he can identify any perforation in the wall, if he can identify any collection around it, if there is a mass or polyps in the gallbladder wall, if he can see a stone impacted in the neck of the gallbladder, if there are multiple collections in the peri-gallbladder area, always remind him that CBD size is very important. A CBD stone can be detected less often by a sonography. It may be missed, but still CBD size should be always be evaluated. Liver echo texture, very often not mentioned on a sonography. If a patient is having an altered liver echo texture, implies that patient is having an impending CLD or a CLD, which will make your surgery more difficult. So you need to make more arrangements for the surgery. Evidence of portal hypertension. EHPVO. I have found most common cause of a disastrous lap chole is a EHPVO rather than a bile duct injury, which can have a more prolonged relief. But EHPVO usually causes a mortality in most of these group of patients if not handled by a secured surgeon, or if not managed on table correctly, because this patient will bleed like hell. Always see that patient may have a sonography report which is printed, which does not have any marking of details of liver. Ask them if they have seen a swollen liver, because this swollen liver can be a missed primary gallbladder cancer and having a metastasis over there, or some other malignancy which may impair your decision to do a lap chole. Always take precautions while doing a USG, that a gallbladder full of stones may paradoxically be hard to visualize, because this is a contracted gallbladder. Severely contracted gallbladder with a postprandial sonography, he may say that I could not see the gallbladder. So that is usually a very common mistake that you can find. A patient having gaseous abdomen, I think you have to be again cautious, because he may not give you full report about the gallbladder wall thickness. Take him in the fasting state so that you can fully visualize a distended gallbladder. If gallbladder is not showing a stone, or gallbladder is showing a stone, sometimes you may require a MR. MR may be required for other diseases, but specifically if we want to see for a stone disease, it will be seen on T1 intense image, T1 images on MRI. That will be a hyper intense area. A hypo-intense area is in the case of cholesterol stones. Similarly, the T2 image showing a signal called a low signal outline image. MRCP will always show a signal void, which may be missed normally on a sonography to see a CBD stone or a gallstone which has not been picked up early. Now, if you have got a sonography report, how to proceed after you have got a sonography report? This is just a minor, with my experience, what I mentioned, maybe some of the things we can be overlapped or can be corrected subsequently. If a USG is showing a suspected CBD stone or an impacted stone or a surgically obstructed jaundice, or you see a dilated CBD without a stone with a normal alkaline phosphatase, get a MRCP done always. USG showing some area of swollen liver, get it confirmed by a CT scan or a MRI of abdomen. If USG is showing a suspicious malignancy or a polyp of gallbladder large size, patient is having pancreatitis, recent history of pancreatitis, recent past history of pancreatitis, patient having gallbladder perforation, patient having a previous surgery being done which is having a prolonged course, get a CT scan done prior to doing a lap chole, because this will aid you in seeing what are the adhesions, how is the collection, how bad will be the abdomen. It will give you a glimpse of that. If you have got a USG which is showing chronic liver disease, portal hypertension, always get an endoscopy. That will show you how much is the portal pressure and if there are esophageal varices present or not. A USG showing a suspicion of stone. A suspicion of stone. This was a recent information to me. One of my colleagues told that color Doppler can show a surge in the gallbladder. We have never got it done, but definitely color Doppler can be helpful. Or if your USG showing a lesion in the ampulla or a CBD, get a EUS. Endoscopic sonography is a better investigation for showing. If I'm running out of time, please let me know, sir, Dr. Chaubey sir and Dr. Sadiq sir, if I'm running out of time.
Yeah, I think another 2-3 minutes maybe.
So USG, then you have to get a EUS done for that. If USG showing a lesion in the mid or the lower CBD, a cholangioscopy is a very good investigation. Definitely MRCP may help. And if USG is showing ascites, definitely CCT and aspiration of fluid for the evaluation is always very important. So you may find very often these findings, this is by experience that some of these things may be present, and how you have to proceed and subsequently evaluate. Don't jump onto the lap chole because you have seen a gallstone on a sonography. So for a pancreatitis, we often prefer that CCT is a better investigation. For a CBD stone, MRCP, malignancies, again CT scan. For a portal hypertension, first is upper GI endoscopy, subsequently CT scan can be done. No stones are seen, then EUS. Sometimes MRCP or MRI can be used, but if no stones are seen and you have a history of recurrent pancreatitis, get evaluated, because most of these patients will have sludge in the gallbladder. A colorectal cyst better evaluated by MRCP, ampullary region by side viewing endoscopy and CT scan, mid CBD stricture by cholangioscopy, multiple periportal nodes. This is very often finding. You will find large nodes in the HDL area, get it evaluated by a CT scan and by a EUS, which can target a FNAC from that area before jumping onto the cholecystectomy, because you may have a large node in the which is called a cystic node, and which may make your surgery more difficult if it is tubercular or if it is a lymphoma. A chronic pancreatitis, always get a CT or MRI done before jumping in for a lap chole. Pre-op ERCP, this is just an additional factor. I'll just point few things that if the patient comes. Today I had a patient who had come following a ERCP which was done 8 months back. So I wanted to add those images right now, but because of shortage of time, because I have seen him just half an hour back. So this ERC, a patient who has undergone a ERCP, a patient who has undergone a ERCP-induced pancreatitis, the timing is very important. Don't hurry. If you have done a ERCP today, no hurry to do a lab chole today. Wait for a day. Let the patient settle. If the patient is having pancreatitis post ERCP, just wait. Don't just rush. Once the patient is settled, we can do a lab chole, but it has to be done before the patient is discharged. In a severe pancreatitis, similarly, wait for the patient to get settled. Don't run by amylase or lipase values. But if the patient's abdomen is settled, you can do a lab chole so as to prevent his or her recurrent episodes of pancreatitis. The tests which are often mentioned but not required are repeat paraoperative cholangiogram. This is not required. Intraoperative cholangiograms, which was discussed in between for a long time, it is not required as a routine unless you need it for a specific procedure. But mind it, if you need to have a habit, do it sometimes before going in for a difficult case. And a HIDA scan, which is no more required nowadays. This is a long algorithm, which I think I don't need to go into the detail. I would like to thank my two teachers, Dr. V.K. Kapoor, who is a teacher of all, and who has been a teacher for us, and Dr. Sadiq Sikora, who is all-time teacher till now for all of us. I'd like to thank both of them to give this opportunity. I have been trained under them at SGPGI Lucknow, and I would be happy if I can answer any of the questions.
Dr. Chaube, sir. Anand, come in. I think we've got Sadiq. You can take over. Sadiq, please.
Yeah, thank you. Dr. Chaube, are you here?
Yeah, I'm here.
Yes,
Please
Dr. Chaube,
go
sir,
ahead.
your comments.
Yeah, thank you, Ajay, for such a eloquent and a very comprehensive coverage of your topic in a time allotted to you. I think the topic selected, thanks to Professor Sadiq and Professor Kapoor, is a very important one. Safe cholecystectomy. As all of you know, that it is the commonest abdominal surgery being performed across the globe. And the incidence of post-cholecystectomy bile duct injury has not decreased despite so much of expertise. As a matter of fact, it has gone up a bit. So this topic is very relevant, and Ajay has covered the topic very comprehensively and in a very nice way. My just advice to the all general surgeons is kindly give adequate importance to the ultrasound. Just read the report, and if you are not satisfied with the report, kindly consult the radiologist and you can repeat it, but you must have adequate information. That is, before the ultrasound is the history taking and the examination. The history taking and examination are very important. So emphasis must be given to the history, as Ajay has told. So all points are very important, and I think with this, I will close my comments.
Thank you, Dr. Chaube.
Questions?
Thank you. Ajay, very nice presentation. There are two questions on the chat. First is by Jayanta Bhaumik. What is the indication for cholecystectomy in asymptomatic cholelithiasis? Can you briefly just list this?
Sir, asymptomatic.
Sorry. Before Ajay answers, let me make it clear to the participants that's a separate topic in itself. So it would be very difficult for anybody to answer that question, but Ajay, yes.
Yeah, I think a very good question, because asymptomatic gallstones are very frequently encountered. And if we see any patient who comes to me with the asymptomatic gallstones, I always tell them to be in close vigilance. And if you have symptoms, you can come for a cholecystectomy at any point in time. I'm available 24/7. That gives them a confidence that yes, in case they have any pain, we can tackle it. But there are specific indications for asymptomatic gallstones to get operated, because very often I get patients who are going to US, suppose, and they don't have a insurance where they can get a lab chole done at US if they, in case they have symptoms over there and they are going for a long time. Actually, in books it has been mentioned that if you are going on a long travel, or you are going into an area where you don't have a medical facility available, get your gallbladder removed. That is safer method. Or anything that, suppose a patient who's having asymptomatic gallstones, you are doing any abdominal surgery, you should do a lap chole with it simultaneously. Any patients who is having asymptomatic gallstones going in for a chemotherapy, minded, these patients are more likely to have complications. So, and some of the books mention a stone more than 3 centimeter size. I don't agree that asymptomatic gallstones alone. But unfortunately, yes, I have had experience, two patients who in last almost 20 years of my experience, who had, I had advised them not to undergo a lap chole, and they had come with a mass in the gallbladder, and which has made, I told Dr. Kapoor few days back only, I think it's hardly a month back, when I told him that now I think should I start doing asymptomatic gallstones as a routine, but still I don't have the courage because there is no link between the gallstones and the malignancy. So telling them that they may have a malignancy is a wrong way to tell that they should get undergo a surgery. But definitely it is not a risk factor, but they can develop symptoms. So there is a huge list of that.
So,
Dr. KJ Singh also.
Ajay, the follow-up question on that is that about diabetic patients. And I just want to emphasize that that's a myth which goes on, that patients with diabetes should have their gallstones removed. So that is not an indication. Similarly, the porcelain gallbladder used to be an indication, is no longer an indication for removal just because it is asymptomatic. Let's take up some other questions. And as a matter of fact, I also wanted to emphasize that I think you have addressed one thing very important, which is ultrasound is not just about gallstones, but there are a lot of other things which we need to look at while we recommend patients to undergo surgery. And you have covered it beautifully. KJ wants to ask a question, and I also reiterate that, you know, what is important is how about the timing of these tests? That, you know, what do you expect? How recent these tests should be? And is there any importance of that in terms of taking a decision?
Yes, I think that's a very valid point. Actually, I had mentioned it in the time factor for a history, but time factor for investigation is equally or rather more important. Very often we get patients who has got a sonography 3 months back, and patient wants to emphasize, I don't want to repeat it. I think that's wrong. Get it right now. And a LFT, that is also equally important. If you have a LFT and a sonography done recently, within we usually prefer within 7 to 10 days. But if he has a longer duration, long back than sonography and LFT, I don't think that I would agree to it that we should continue with the lap chole on that, because the patient can have a fluctuation. But if the patient is absolutely symptom free during this time, maybe sometimes we can, but I think 95% of the time I don't.
I would say that if patient is having persistent or recurrent episodes of pain, then it is wise to get it immediately prior to surgery, especially LFT and an ultrasound, because that will give you a little more information. Otherwise, I think a week or 10 days or even a month, if the patient is asymptomatic, should be fine. One interesting question here is by Kaushik Bhattacharya. Is there a role of routine MRCP in patients undergoing cholecystectomy?
No, there is no role of a routine MRCP. MRCP has specific indications. I think I mentioned that if the patient is having a dilated CBD, suspected CBD stone, increased alkaline phosphatase, you suspect a cold cyst or a cold stone into it, then, and sometimes I think we have slightly extra expanded our intent to do MR. Sometimes the patient is having no gallstones, patient is having pancreatitis. We often get a MR done to establish that there is a slump in the gallbladder, because earlier it used to be a Metzel ion test, which is a non-practical test. So easier investigation is EUS or MR. So I think that is one indication which is not commonly used.
So his concern was that, you know, missed CBD stones or CBD stones which are asymptomatic, which may be in 5 to 10%. Post-operatively, if they become symptomatic, it may be difficult for the surgeon to deal with. That's his argument. So, I mean, I agree with you that we don't do routine MRCP. There are some, you know, surgeons or groups which are recommending doing a routine MRCP so as to identify the anatomy prior to cholecystectomy, but I think it is too much for too little benefit at this point of time, and routine MRCP certainly is not the option.
I think there are some questions above this.
Yes. How do you deal with, so this is Dr. Vishu. How do you deal with cholelithiasis in pregnant patients? Now, it's a long thing again, as Dr. Kapoor mentioned, it's a topic in itself, pregnancy, but briefly, in asymptomatic or detected during pregnancy, and symptoms during pregnancy. You know, a lot of times I get patients referred by gynecologists saying that we are planning a baby and I have gallstones. Should I get it removed?
I think the answers to this are if a asymptomatic gallstones, we don't remove them if the patient is getting pregnant, because they may have symptoms, they may not have symptoms. But if the patient is pregnant and you have a gallstone, patient can have pain related to gallstone or unrelated to gallstone, but we usually consider it to be related until unless proved otherwise. And best time is to go into second trimester. If the patient has had a smooth second trimester, no pain in the third trimester, definitely it is a difficult time to do a laparoscopic cholecystectomy. We prefer that the patient let her get delivered, and after a month or so, we will like to have a cholecystectomy done in this group of patients. If the asymptomatic patients with pregnancy, yes, definitely there is increased chance that the patient can have symptoms. We have to explain that itself is not an indication for a laparoscopic cholecystectomy.
Right.
There's another one about Miridzi.
Pardon, sir?
There's another question. Jayant Bhaumik wants to know, what are the indicators for Miridzi syndrome clinically and on ultrasound? And I would add LFT also.
Miridzi is actually, the definition of Miridzi explains everything. The Miridzi is a patient of gallstone having obstruction in the CBD causing a obstructive jaundice. So if the patient is having gallstone, which has not yet gone into the CBD, patient can have a gallstone with a CBD stone. That is a different era. But a stone impacted in the neck of the gallbladder, causing an obstruction over there, which can erode into the CBD partially or completely. That will lead to an obstructive jaundice. So the patient should have jaundice, which should be obstructive in nature with an increased alkaline phosphatase and a GGT and a dilated IHBR proximal to it. So that is the basic thing that is required with a stone impacted in the neck. That is the critical part. So that compiles the complete Miridzi syndrome.
I think Dr. Chaube sir wanted to say something.
Yeah, just about the asymptomatic indication of asymptomatic routine cholecystectomy. I think certain professions, particularly the fighter pilots, because fighter pilot flies the plane alone, and if he develops plane, it's a disaster. And also the naval people who are going on a long stay, boys, or all the even the marine people who are on a long voyage. I think there one can consider the cholecystectomy in an asymptomatic gallstone.
You may make some concluding remark and then we will move on.
Actually, Dr. Chaube, I agree with you. A lot of the, even pilots, actually, they need a fitness. And even if they are asymptomatic gallstones, they are required to get it out. But I think this is, in my opinion, this is a very important aspect of going in for a cholecystectomy, is to understand what are the things around the gallbladder which may determine the outcome. And Ajay has covered this beautifully. So the key points are: history is important, symptoms recurrent, liver function tests always see very critically, ultrasound should be done by an expert or somebody whom you know, that you would provide you with all the information. And I personally don't accept any ultrasound as enough to diagnose gallstones and carry out the surgery unless I have all the information which Ajay has listed. And finally, you should be able to define the next step after an ultrasound based on what you find on that. And Ajay has also listed that. I think it's a brilliant start to this, to get this perspective of gallstones. Thank you very much, Ajay. And Dr. Chaube, thank you very much for sharing this session. We'll go in for the next one. Dr. Kapoor.
Yeah,
Thank you.
so I see Professor Mo Maint from Myanmar has joined. Welcome, Dr. Maint. I hope that we will have more collaboration between Burmese or Myanmar surgeons and Indian surgeons, and I welcome you to this masterclass. Thank you very much. I would be happy if at any stage you would like to make a comment, just please put it on the chat. I also see so many other senior persons. I'll identify and name them in between. So we move on. Thank you, Ajay. We move on to the next presentation, which is by Dr. Muhammad Ibrarullah from the Apollo Hospitals in Bhubaneswar. He again is an SGPGI alumnus from the very first, second batch. And he again is very passionate about keeping cholecystectomy safe. He is, along with Dr. Sadiq, he has produced a very beautiful, very well illustrated atlas of cholecystectomy, which I would request that if everybody can request their institution or department to get a copy. And to chair this session, I welcome my another young faculty colleague. Shaswat, can you come on screen, please? Dr. Sareen, who's my colleague in HPV surgery and liver transplant. He trained from ILBS, and recently he has had a more than 6 month fellowship with Dr. Mohammad Reila. So over to you, Shaswat.
Hi, sir. Good evening. Thank you for having me. I'll not waste too much time and leave the time for discussion at the end. Just welcoming Professor Ibrarullah, who is a very senior surgical gastroenterologist from Apollo Bhubaneswar, who's had more than 100 publications to his credit. His topics of interest, as sir had said, are biliary pancreatitis, safe cholecystectomy, including some very good publications on single-sitting lap cholecystectomy along with the ERCP. He's also got deep interest in radiology and has published a number of signs, the Christmas tree sign and the cauliflower sign, all of which are surgical correlations with radiology, which we can learn from. And more recently, he's actually published something which is very, very pertinent to the topic that Sir has given him to speak on, which is in recently published 500 patient prospective study on anatomical appraisal of a safe cholecystectomy, which is a wonderful read. I'd recommend everybody go through it. But without further ado, I'd request Professor Ibrarullah to kindly start his talk.
Good evening, everybody, and thank you, Saraswat, for the kind introduction. So, is it visible now? My screen?
Yes, it's visible, Ibrar. Go ahead.
Yeah.
Put it in. Yeah. Slideshow now.
Some years back, or even today, like some surgeons, this is how they would do the cholecystectomy. This is what I have tried to show. Like first, retract the infundibulum. This pictures I've got from another colleague of mine. This is how he does cholecystectomy. So are many other surgeons do it. Sorry. Retract the infundibulum, dissect out the tubular structures, presume this to be cystic duct and cystic artery, apply clips and divide. So the point is the dictum of safe cholecystectomy says that do not ever presume. You must always confirm the structures before you clip and divide. Because the most common cause of injury during lap cholecystectomy is perception error, or what is otherwise called the misidentification of anatomy. If you look at this picture, like on the first impression, this entire structure looks like cystic duct. But as you dissect further, what comes out is only this segment is the cystic duct and the remaining is CBD, what initially you thought to be cystic duct. Similarly here, like what appears as a cystic duct coming straight away from the infundibulum or the Hartmann's pouch of the gallbladder. Eventually what we realized, this was a common bile duct, not cystic duct. And here again, this first impression that this is a cystic artery. But as we dissect further, we realize this is actually a right hepatic artery from which a small cystic artery is arising, which has eventually been clipped and divided. So the point is, how do you prevent this perception error? This is how you do it. Identify the anatomical landmarks, dissect in the correct plane, isolate cystic duct and artery in the hepatocystic triangle to achieve critical view of safety. This is the single most important technique in prevention of injury to the bile duct or to the vascular structures during cholecystectomy. The concept of critical view of safety, or CVS as we call it, has basically three components: dissection of the hepatocystic triangle to clear all fibrofatty tissue, then demonstration of two and only two structures, that is cystic duct and cystic artery joining the gallbladder, then dissection of the distal 1/3 of the cystic plate, that is removal of the distal 1/3 of the gallbladder from its bed. So these are the three components one must try to achieve so as to, this is what is called critical view of safety. Now coming to the first important anatomical landmark, that is rubeus sulcus. When you start dissection, you can have you can make out this is what the rubeus sulcus is. To get a better view, just flip the gallbladder, you can get a better view of this rubeus sulcus, and you can see this portal structures are basically containing into the sulcus. This basically contains the right posterior sectoral pedicle. So this is one landmark. Other landmark is this base of the segment 4, and then the umbilical fissure. This umbilical fissure is basically the medial extent of this important structures in the hepatoduodenal ligament. So that should form as the limiting factor when you're dissecting. And this particular line, which is called R for you line, is a very important plane, because during dissection of the gallbladder, you must remain ventral to it. That is how you protect the bile duct. That is how you carry out a safe dissection. Look at this picture. This is where you start your dissection. That is, you're remaining above the rubeus sulcus and remaining close to the gallbladder. That start the dissection. So, we have actually analyzed 500 cases, which Dr. Mittal has just mentioned. So on the basis of that, we have suggested a classification of the rubeus sulcus, where we divide them into 4 types depending on the appearance. This is type 0, when there is no rubeus sulcus, the rubeus sulcus is absent. This is in about 23%. And in about 40%, you get a deep sulcus, which is called type 1 sulcus. Deep sulcus, which is open in the medial end of it is open. This is 1A, 1B, where the medial end of the sulcus is closed, and 1C, where it is fused in the middle. You can see it clearly how it is containing all the portal structures, this rubeus sulcus. And this is type 2, where you find a small slit-like opening away from the hilum. This is less than 1 centimeter in its dimension. This is type 2. And type 3 is a fused sulcus represented by a scar. Type 4 is a very rare variety. This is one of Dr. Sadek's patient. He had shared this photograph with me when you are doing that book. So this is basically, there are double sulcus. You can see here there are 2 sulcus, one here and one there, and both of them seem to be containing the portal pedicle. To give you a correct perspective of this rubeus sulcus as a landmark for dissection, I've just, this is one recent lab fill that I had done. I picked up this for today's discussion. As you flip the gallbladder, you can see this rubeus sulcus and there's all these portal structures going into it. It's not very clear where to start the dissection from. So this rubeus sulcus forms the main landmark, and you try to, you start the dissection above the rubeus sulcus close to the gallbladder. If you start dissecting, you can see this infundibulum is beginning to get separated from this portal structures, which is going into the rubeus sulcus. Further dissection, this infundibulum has been completely dissected off. This is what the cystic duct, where we have placed the clip. And just see, this is the rubeus sulcus. We have placed the clip above that. That is the safest point where you should really, apply the clips. And this is the anterior view of that. If CVS has been achieved, this is the cystic artery, cystic duct, and the clip there. And this is the rubeus sulcus. You can see it. It's above that. After division, you can see the level of the cystic duct with relation to the rubeus sulcus. Sorry.
বুঝতে হবে কি আছে কারণ হচ্ছে আপনার যে অপারেশনটা আপনার করা হচ্ছে
You please mute your mic, please.
বড় ধরনের একটা বড় ধরনের একটা
Avinash, can you make?
Thank you.
Yeah. From Rubius sulcus, now let's move on to the next important structure, that is the cystic artery. This is basically a textbook description of the cystic artery with respect to its origin and the course. But then this is not so much important, because what is important for cholecystectomy is the disposition of the cystic artery in relation to the gallbladder in the hepatocystic triangle. That is what is important. So what we have. Sorry. Yeah, so these are basically 4 types of cystic artery that we have come across in our dissection of 500 cases. I'll show you what exactly is this. This is type 1, where you have a single cystic artery medial to the cystic duct in the hepatocystic triangle. In fact, this is the kind of cystic duct all of us have in our vision when we are doing a cholecystectomy. This is found in about 77%. And this single cystic artery usually divides into 2. This is the superficial cystic artery, which goes in towards the infundibulum, and the deep cystic artery, which goes between the gallbladder and the gallbladder bed. This is what we can see, the superficial artery and this deep artery. Commonly, like what we call this as anterior cystic artery, and this is the posterior cystic artery, but there's no such nomenclature. They are actually called superficial and deep branches of the cystic artery. So you can see here the superficial artery and the deep cystic artery. But what is important here, that this division is close to the gallbladder. So a single clip at the main trunk would suffice for the both. On the other hand, there may be early division of the cystic artery. They divide well, well below, in the sense there is a long segment of superficial artery and deep cystic artery in the hepatocystic triangle, each requiring separate division. So this we call it type 1M or type 1 multiple. This we found in about 5% of patients, early division of the cystic artery. This is type 2 variant, where the cystic duct actually comes from below, crosses the cystic duct to enter into the gallbladder. This can cross anteriorly or this may cross posteriorly in some cases. This basically has its origin from the gastroduodenal artery. This is, we have labeled as type 2 cystic artery, and this we have found in about 8% of patients. This is actually the same type 2 cystic artery, but with an early division. This is a superficial division. This is the deep division of the type 2 cystic artery. Look here. Initially, we thought this is the cystic artery, but as we dissected further, we realized this is a right hepatic artery hump, giving a small cystic artery here, which is again bifurcated into the superficial and the deep division. This we found in about 2.4%. This we call type 3 artery, that is the right hepatic artery hump. Same here, a right hepatic artery hump giving out a small cystic artery. Yeah. And this is after division, you can see a small cystic artery. This is the cystic duct, and this is the right hepatic artery hump. This is type 4 or double cystic artery. In fact, we have 2 separate arteries coming at 2 different planes and entering into the gallbladder. So since they are in 2 different planes, means they have their origins at 2 different places. This is type 4 or double cystic artery. So what is important is nearly about 25%. I mean, if you this 23%, that's nearly about 1/4 of the patient. The cystic artery has either abnormal course or abnormal number. And that is what has to be kept in mind, because lack of awareness of this may predispose to injury or bleeding during cholecystectomy. Now about cystic duct, this is again a book picture giving, telling you about different types of cystic duct, their course and how they get inserted into the CBD, crossing it, something is parallel to it, and somewhere it is fused with the CBD. The same pictures also you get to see when you do MRCP on these patients. But let me tell you, from cholecystectomy point of view, this is not important. Because for safe cholecystectomy, it is important to define the gallbladder cystic duct junction and dissect the cystic duct as far safely as possible. And it is not important to define the CBD cystic duct and CBD junction. The only place where it may be important that you have a retrocholedochal cystic duct and there's a stone in it, that is difficult to take out. That's the only practical problem. But otherwise, for routine cholecystectomy, it's not really required to dissect the entire course of the cystic duct or to define the cystic duct or CVD junction. So this is how, I mean, from practical point of view, this is the kind of cystic duct we encountered. We classified them into normal, wide, short, short and wide, long, long and wide, and sessile. The normal means it's usually the dissected length was within 2 to 4 centimeters, which would normally take a 200 to 300 size clip. That we found in the majority and about 68%. On the other hand, in 14%, we had wide cystic duct, which would perhaps require a 400 size clip or a ligature for its for securing it. These are some examples of a long cystic duct. This is a parallel cystic duct. There's a cystic duct and there's a CBD, so it is running parallel to it. There's a short and wide cystic duct. This is a normal length but wide cystic duct. Having done with the cystic artery and cystic duct, you think the major part of the surgery is over. It's not so, because dissection of the gallbladder from its bed is equally important. You have to really identify or stick to the cystic plate, which is basically a fibrous layer between the gallbladder and the liver bed, which has many important structures within it or below it. So that's the reason you have to really stick to this plane and dissect it carefully. But then there are times because of inflammation, you may not be able to get this plane correctly. So there may be breach in the cystic plate. As you can see here, there's whitish patchy area, the real cystic plate, and these other things are the breach in the cystic plate. So what happens if you don't remain in the correct plane? Or you don't correct it, you don't dissect it correctly. The structures superficial to the cystic plate are at rest during dissection of the gallbladder bed, and these structures could be deep branch of the cystic artery, as you can see here, aberrant right hepatic artery at times, or segmental artery running in the gallbladder bed that we have seen quite often, or a cholecystohepatic duct in the gallbladder bed entering the gallbladder might get injured as you dissect it. Of course, that is unavoidable. If it is entering into the gallbladder, you have to purpose divide it, but then you need to identify it. As you can see here, this is what, like that during dissection we divided without realizing what we are dividing. But after division, then we could see some bile spillage in this gallbladder bed. Try to identify it by giving good wash and all that. We could identify this bile duct opening here or small biliary duct opening here. That was finally around it and that controlled it. And the structures which are deep to the cystic plate, which are at rest during dissection, are the hepatic vein tributaries or subvesical duct. This hepatic vein tributaries, it's important to know that they could lie as close as 2 millimeters from the cystic plate. So if you dig little more, you're going to hit them and there's going to be a real disaster. I'll just show you that in a video, my next clip. Look at this. This is after the cholecystectomy, after the gallbladder was removed. You can see this structure. You can see a distinct pulsation here. I'm sure you're able to appreciate that. I'll replay this video. Look at this area. There is a pulsation here. Hepatic veins do have pulsation. So obviously this is a large size hepatic vein which is in the gallbladder bed. Fortunately, we have been able to save it. We identified it after removing the gallbladder. But just think of it, if little, you dig into that gallbladder bed and hit that vein, and what would have been the consequence?
Ibrar, another 2-3 minutes.
I'm getting over. Yeah, this is the last slide. So the important thing is awareness of this variable anatomy and a careful dissection of the hepatocystic triangle and displaying the anatomical structures is the key to safe cholecystectomy. And that is what the take-home message should be from my side today. And as this was mentioned, that this is a recent publication and most of this material of this presentation are from this particular study we have done. Thank you.
Ibrar, if possible, can we put this article on the JST website so that people can go through?
Sure, sir. Why not? There's already online.
Okay, yeah, but we can get it. Anand, maybe we can put it on the JST website. Shashwat,
Sure.
there are some pending questions also, which maybe Dr. Ibrar can take.
So that was an excellent presentation. So that was exactly what we needed with regard to the anatomical perspective, especially with the prospective study. I went through the paper. It's actually really, really good. And I'd recommend every resident go ahead and read it. I had 1 or 2 queries, sir. One is
Yeah,
when you
please.
classify the Ruvius sulcus, do you have any relation to your surgical approach?
Sorry.
So while classifying the Ruvius sulcus, did it have any clinical correlation to how you approach the patient? Like that is an anatomical classification, or it doesn't have any management perspective as well, sir?
No, it serves as a landmark only, nothing else to do with the dissection or anything. That's the landmark, but you need to know that there is a sulcus and this is how it might appear during surgery. So that's all. Yes.
So one more question just before we open to the audience is that in the presence of inflammation and pathology, which isn't simple and it's all scar, it can be a cirrhotic patient or inflammation, where there aren't landmarks available. When it is difficult to actually find, and that area around the cholecystic triangle and the hepatocystic triangle, are there any approaches that you would see to better delineate the anatomy?
No, number one, like in a significant proportion of patients, this Ruvius sulcus is absent. So what we do is lift a gallbladder up. Even if the sulcus is absent, we'll get an impression as to the course of these portal structures as they enter the hilum. So from there, you know where is exactly is the plane where the sulcus should have been. Even if it is not there, at least you can make out where it should have been, and you start dissection close to the gallbladder. That is number one. Number two, there are other landmarks also to fall back on. One, as I said, the base of segment 4, that's an important landmark. When you're dissecting, never try to go medial to the falciform ligament or the umbilical fissure, because that is the limit of all these important structures in the hepatoduodenal ligament. Besides, if you cannot make out an anatomy, there are alternative techniques which you follow. One of them is, of course, the artery first method, which we have mentioned in our book, that artery, if you divide it next to the lymph node on the gallbladder bed, then it's fairly safe. This is very rarely there will be variation there beyond the lymph node on the gallbladder bed. Once you divide the artery again, you have got some planes to dissect and to delineate the anatomy. So these are a few structures, and when you cannot delineate the anatomy, of course, there are other methods of alternative methods of retrospect and partial subtotal, all this. Yeah.
Ibrar, maybe you can take the questions from chat, starting from Jayant Bhaumik, which is ideal timing of surgery in acute cholecystitis. Although it doesn't relate to your talk, but I think we need to complete all the questions.
No, but
I suppose this is going
that's
to be
the next
discussed
talk.
tomorrow.
That's the next talk.
Next talk is
Okay.
there.
Okay.
That's the next talk.
Yeah. And following that, there are Shashwat, maybe you can take the questions.
Yes, I think there's a comment from Dr. Ajay sir, that in a subtotal cholecystectomy, we divide the gallbladder far away from the Ruvius sulcus and giving enough space to close the gallbladder neck and be away from the CBD and be able to look inside the cystic duct opening from the inside. I think that's a comment. I don't think there's a question there. There's a question from Dr. Shalu Gupta, which says, how do you identify the cholecystohepatic duct during surgery?
So Dr. Shalu is one of the senior surgeons from Jaipur, and she's also a member of the executive of the ASI, and she's also one of the faculty members for the masterclass. Yes, Ibra.
Yeah, there are actually, if it is a subhepatic duct, it's different, because if you're digging deep into this thing, you'll injure that subhepatic duct. But if it is a cholecystohepatic duct, you are bound to divide it, because that is draining into the gallbladder. So in the course of removal of the gallbladder, you are bound to divide that, or you have to divide that. There is no choice there. But once you divide it, there will be bile leakage. Particularly what we have seen, that sometimes the bile might come from the gallbladder side once you divide it, because the cholecystohepatic duct is a communication from both sides. Once you see the stain on the gallbladder, then we suspect maybe like there is something which is draining into the gallbladder. Then we look for it more carefully. And besides, like whenever we remove the gallbladder from its bed, we just do not close it. We spend some time looking at the gallbladder bed to see if there is any speck of bile, or is there any bile spill or something that we can pick up. Particularly when the dissection is difficult, we definitely spend some time inspecting the gallbladder bed rather than just leaving it, removing the gallbladder and closing it altogether. So only by inspection, you can detect it. Otherwise, there is no other way you can really find.
The next question is from Dr. Ajay, saying the guideline and how to define that we have to close the opening of the bile duct showing a bile leak in the gallbladder bed, or do an RY do a FJ to this opening? Think how big it should be?
Unlikely. If it is in the gallbladder beds, obviously this is a cholecystohepatic duct, which is very small. So any duct which is less than 4 millimeter is an insignificant duct, is not a significant duct, or it's not draining a significant segment of the liver. That can easily be clipped or closed. If it is draining, if the duct is draining into the bile duct, then it becomes important. That is a significant. Usually the sectoral duct would drain into the bile duct. But if it is into the gallbladder, very unlikely that this is a segmental duct.
Next question is from Dr. Kaushik Bhattacharya. How many times does the cystic artery get injured while dealing with a large or hard cystic lymph node?
Large hard cystic lymph node. Never. I mean, till we adopted this technique, we are injuring the cystic artery, if not the anterior artery, if not the posterior artery or the deep artery, we are injuring quite frequently. But once we are now meticulous with our dissection, we seldom come across this problem of injury to the cystic artery during surgery. You almost always identify it and protect it.
So could you open the slide for the Ruvius sulcus? I think Dr. Sampath wants to see it while we answer the other questions, sir. The next question is we've already covered in case of a frozen calyx how to go with these landmarks, sir. I just covered it. And then the question from Dr. Naomi is, how do you manage a Luschka injury intraoperatively, which I think you also just covered right now?
First of all, this duct of Luschka is a misnomer. There is no such thing like duct of Luschka, because what was discovered by Luschka was some biliary radicals in the gallbladder bed in the dissected specimen or in the histopathology, which may not be really, probably what he means is a cholecystohepatic duct. I mentioned it. I mean, I've already said that once you identify that, once you identify the opening, you have to either take a suture bite, or if it is clippable, then you apply a clip.
Sadiq, any closing remarks?
Yeah, Ibrar, thank you very much. Always beautiful to see your slides. Regarding one point which Dr. Shashwat made, and I want to address that is, apart from all the landmarks which Dr. Ibrar said, I think one very underrated landmark is the cystic lymph node. And the situation that you say in the cirrhosis and things like that, where the other landmarks are obliterated or not very clear, I think lymph node is a great landmark to proceed, where to proceed your dissection for. And so I feel it's a very constant finding. It is a safe area. And as a matter of fact, if you put a line perpendicular and parallel to the hepatoduodenal ligament across the lymph node and bisect this R4U line, you get a quadrant where it is much safer to operate, which is outer quadrant. So I think lymph node we should keep in mind to be a very important landmark. Ibrar, I've also now we are seeing that we are able to preserve a lot of these deep
exactly, yeah.
And we don't know whether they're supplying some segment of the liver. So I think the two components of identification and then remaining close to the gallbladder would help preserve even small vessels which may supply some areas of the liver. So having said that, I think this topic has been beautifully covered, and it makes a lot of sense now to how to look at anatomy while doing a cholecystectomy, which is how you need to sort of tailor or sort of educate your mind to look at, rather than the anatomy in a cadaver or things like that. So thank you, Ibrar. Shall we move on, Dr. Kapoor?
Yeah. So there are just two comments. Dr. Monica Gupta, again, one of the senior GI surgeons in Jaipur, completely kind of reiterates Dr. Sadiq's comment that lymph node is a very important landmark. And Dr. Vishal Gupta, who's the chief of GI surgery at AIIMS Bhopal, says that the final check that after the removal of the gallbladder from the liver, and I would say even after extraction, look for BBC, bile, blood, and clips. So these are some important points. So with that, we close this part. Thank you, Ibrar. Thank you, Shashwat. And we move on to the next presentation, to chair which I would like to invite another of my young faculty colleagues, Dr. Vinay Mahala, who got his training in GI surgery from KEM. And after that, he's been with us as an associate professor of surgical gastroenterology, is a active member of our transplant team, along with Anand and Shaswat, which is now being led by Dr. Namish Mehta, who has joined us from the Sir Gangaram Hospital. And Vinay will be chairing this session. And the speaker is Dr. GSB Kishore, who's currently a senior consultant GI surgeon at Fortis in Bangalore. Kishore, please come in. Over to you, Vinay.
Good evening, sir. Now, I would like to invite our next speaker, Dr. Kishore, GSB. Dr. Kishore is a senior consultant and clinical head, HPB Surgery and Liver Transplantation Program, Fortis, Bangalore. Sir has a vast experience of more than 20 years in the field of HPB surgery and liver transplant. And sir is an ex-alumni of PGI Chandigarh. So I would not take too much time to introduce sir, as Dr. Kapoor has already introduced him. So sir, now the session is to you to start your slides, sir. Dr. Kishore, sir.
Good evening, everybody. Am I audible and the screen is visible also?
Yes, please.
Thank you, Professor Kapoor, sir, and Sadiq, sir, for this opportunity. The talk is on timing of cholecystectomy in 3 specific situations: acute cholecystitis, biliary pancreatitis, and post-endoscopic retrograde cholangiography. So, why is timing important in surgery? So, operating too early, the risk-benefit ratio may not be in favor of surgery. This we see in asymptomatic gallstones, where we don't want to operate and take the risk of surgery. Or it may not be technically sound because of the natural history of disease, like in the first week of severe acute pancreatitis, where we don't operate for gallstones. Operating too late also has its problems, and the disease process may cause complications, like a gallbladder stone can slip into the bile duct, cause pancreatitis, and therefore it is actually important to find when is the right time to operate. Now, finding the right time is not always ideal, because patients don't present in the right time, nor do diseases come at the right time. But the right time would be when intraoperative difficulty can be minimized and when morbidity can be reduced as much as possible. Now, when we think of intraoperative difficulty, it depends on a lot of things. It depends on the nature and stage of the disease. You can imagine this with respect to gallstones, but it applies to everything. It depends on the condition of the patient. It depends on the operating setup and the equipment and the team support that we have. And of course, surgical expertise is also important. Therefore, it is obviously a relative term when we talk about intraoperative difficulty. When we talk about morbidity in gallbladder surgery, and specifically with relation to timing, we have to look at the risks of waiting with gallstones versus the risk of surgery. Risk of waiting would be biliopancreatic problems, that is having biliary colics or cholangitis or pancreatitis. And the risks of surgery in an acute setting or in difficult situations would obviously be bile duct injury, conversions, and other surgery-related morbidity. Now, all this has to be balanced with patient safety, the duration of hospital stay, and costs. So this is how we picture ourselves when we make a decision about timing a cholecystectomy. And these are the metrics that are used in all journals and all publications to decide when they talk about timing of cholecystectomy. So that's why I've put up this. And in the next few slides, we'll look at some evidence for each of these 3 scenarios and see how we can make decisions as to the timing of surgery in these situations. So acute cholecystitis first. So if you look at large registry data spanning over many years, most of the time it has been found that lap cholecystectomy done within 48 hours of onset actually results in good outcomes. This is a busy slide, but this is a systematic review of RCTs which have been published on surgery in acute cholecystitis. Acute early surgery is defined as surgery within 7 days of onset of symptoms in almost all of these. and delayed cholecystectomy is defined as after 6 weeks in most of them. Now, the results were that early cholecystectomy results in lesser costs, lesser hospital stay, lesser wound problems, without increase in biliary injury or in morbidity. And there was no difference when patients were operated within 72 hours or up to 7 days. This is a recent meta-analysis. It is a network meta-analysis whereby it takes into account the different durations that were taken, like 24 hours, 48 hours, 72 hours for early, and delayed like 7 to 5 weeks and 6 to 12 weeks. So the message from this paper was operating within 72 hours actually results in the best outcomes in terms of conversion, in terms of hospital stay, and there was no difference in bile leaks or postoperative complications. It is a well-established fact that operating within 24 hours or 72 hours, there's no difference in outcome. And while operating between 72 hours and 7 days, that is between 3 and 7 days, we should remember that we will anticipate a difficult cholecystectomy. By definition itself, this becomes grade 2 Tokyo, more than 72 hours. Still, lap cholecystectomy is the best option. We have to expect a difficult cholecystectomy, and bailout procedures like subtotal cholecystectomy may be required in this instance. And it is always better to do this in an experienced setup. So you should evaluate your own surgical skills and the setup you're in before you take on such a patient for a lap cholecystectomy. There is recent data which says that operating even beyond 7 days in acute cholecystitis actually results in similar outcomes when compared to patients operated less than 7 days in terms of biliary injury, bile leaks, and hospital stays. This is, of course, a retrospective study, but we should remember that when we interpret data, we should look at it carefully. If you look at center experience when operating more than 7 days after onset of symptoms, this particular multi-center study, although it was a retrospective analysis, they defined high volume centers as more than 35 cases of acute lap cholecystectomies for acute cholecystitis per year, and low volume centers as less than 35. It was found that the duration of surgery, bleeding, other complications, bile leaks, they didn't specifically mention bile duct injuries, but bile leaks, all were obviously better in the high volume centers. An interesting finding of this study was the morbidity was not different when people were operated in high volume centers before 7 days or even after 7 days. So the message is you can take on cases after 7 days of onset, but it has to be a high volume center and performed by an experienced surgeon. Obviously, the risks of waiting are biliary problems, like we discussed. This gives a number to all those problems. The probability of gallstone-related events can be as high as 30% at 1 year, and pancreatitis about 6 to 9%. So it is a significant morbidity by waiting on a patient with acute cholecystitis. So early surgery, when safely performed, is good. So grade 1 Tokyo, lap cholecystectomy, especially if the timing is less than 72 hours. There's no confusion here. 72 hours to 7 days, we have to anticipate a difficult cholecystectomy, and it has to be done at an experienced center. More than 7 days, you have to be very, very choosy, not for everyone to do. And patients on blood thinners is a separate topic, but these also generally you should temporize. And grade 3 acute cholecystitis with organ failure and patients who are too sick, it is always good to defer the surgery and optimize them before going in for a surgery. So in summary, it is very clear that from evidence, we all know this as a matter of fact, but I'm just discussing the evidence. Within 72 hours of onset, lap cholecystectomy is always a good choice. And this really works because delaying the cholecystectomy causes delayed biliary problems, and it also increases overall hospital stays and costs for the patient. Now, the second part, we finished acute cholecystitis. The second one is biliary pancreatitis. So there is a good paper. This is from the Ames group. This is again a systematic review and meta-analysis of all RCTs that are published. So this is a forest plot. If you look at recurrent biliary events, there are two groups here, the early group and the delayed group. So these are the number of RCTs. If you count them, there are 7 here. So 7 RCTs. This diamond is the effect size. It clearly favors early cholecystectomy. Why? Because if you look at biliary events, the biliary events were only 9 out of 428 patients. That's 2% in people operated early. Whereas the biliary events were 133 out of 439. That's about 13% in people who had a delayed cholecystectomy. So clearly, operating early for biliary pancreatitis results in lesser biliary events. Similarly, recurrent pancreatitis, the effect size is very, very clear. It is for early cholecystectomy. Early, when I say it's less than a week and preferably less than 3 days. Again, pancreatitis 1.3% in people who had a cholecystectomy early, whereas 7.6% in people who had a delayed cholecystectomy. Instances of acute cholecystitis were 3% in the delayed group, 0 in the early group, and need for ERCP also was lower in the early group. Surgical complications were not different. So what this essentially says is it's quite a conclusive sort of evidence with multiple RCTs which have no bias. And so it is very safe to say that same admission cholecystectomy has a clear advantage in mild gallstone pancreatitis, and delaying surgery results in biliary colic, significant readmissions, and pancreatitis, which sometimes can become life-threatening. So that's about mild pancreatitis. In moderately severe and severe acute pancreatitis, there is not much hard data. There are no RCTs. It is a common sense approach. If the pancreatitis is severe, patient is an organ failure, patient is in ICU, we wouldn't want to do a cholecystectomy. And management of the pancreatitis takes precedence. At some stage, if the patient is operated, especially by minimally invasive approaches for pancreatitis, if the local conditions are not hostile, and if the surgeon is confident about a safe cholecystectomy, it can be done. Otherwise, generally in these situations, it is usually done after 3 to 6 months. Now, the third part of the talk, after ERCP. Now, after endoscopic sphincterotomy or ERCP, this is again a RCT which compared early cholecystectomy and delayed cholecystectomy after 6 to 8 weeks. Again, the same metric, recurrent biliary events and complications related to that are much higher if patients are offered cholecystectomy in a delayed fashion. So even in population-based studies, it is quite clear that having a cholecystectomy early reduces the risk of having adverse biliary events by as much as 90%. So British guidelines, Dutch guidelines, they say that it should be done within 2 to 3 weeks. And the costs in this depends upon the setup, the insurance, and so many other things. There is also, since we're talking about timing and ERCP, there is also this intraoperative ERCP which can be done. And the pros are it causes lower risk of pancreatitis because we cannulate the cystic duct and give the endoscopist a wire through the papilla. So the chances of entering the pancreatic duct are almost negligent. And it's a single anesthesia in patients who have comorbidities. But the cons also are significant because if you really try to do it, the logistics are not easy to arrange, the timings, the equipment, everything has to match. And it needs a very close cooperation between the surgeons and the gastroenterologists, and they should have good understanding, both should have good understanding of how it works. Otherwise, it will lead to a lot of problems. And if you don't time the cholecystectomy well, they insufflate, and if there's a lot of the bowels get distended, it's difficult to perform the cholecystectomy. So the sequence and everything should be sorted out beforehand, and it should work well. In specific patients, it really works well, but most centers have not adopted it as a routine. And
sure, another 2-3 minutes, please.
Yes. If it looks at, thank you. If it looks at evidence, if we look at evidence, again, this is, it's a it says that there's no difference in the CBD clearance rate or complications, but there's a lower instance of pancreatitis and cannulation failure. So most of the time in practice, what is done is we wait for about 24 hours after the ERC, look for complications, and then do the surgery. Now, the rationale of that is sometimes ERC causes complications which can become life-threatening, like pancreatitis, which occurs in about 6-7%, bleeding in about 2%. So if this occurs, it will be a confounder after surgery, and we are wondering what happened, and the delayed recovery is there. So it's difficult to explain to patients. So it's always good to wait for 24 hours and then do the surgery. Just a couple of slides on percutaneous cholecystostomy. It is pertinent because of the timing. So there is again retrospective data for this. The evidence seems to suggest that it is better to do it after 2 weeks when the local conditions are a bit settled and blood loss and conversions are less. So at least 2 weeks of waiting is what is recommended. So the final 3 slides, take-home points. In acute cholecystitis, presentation within 72 hours, it's clear-cut. We should offer a lap cholecystectomy. Between 72 hours and 7 days, it depends on center experience and surgeon experience, but it is still good to offer. More than 7 days, please be very choosy about offering surgery. It may be temporized to do this. It may be safer to temporize the surgery. In mild biliary pancreatitis, very strong evidence to do lap cholecystectomy in the same admission. Moderate to severe, it's a common sense approach. Pancreatitis management takes precedence. After ERC and stone clearance, after 24 hours, but preferably within 72 hours. And post cholecystostomy, I've just put a figure of around 3 weeks, but it has to be individualized based on patient condition. Thank you very much.
Vinay.
Yes, sir. Sir, Dr. Kishore, sir, first of all, I would like to congratulate you for such a well-organized, evidence-based, specifically because you have included all those evidence-based studies for all three situations which we, being as a surgeons, are routinely dealing in our day-to-day practice. Because most of the centers, I think, the crux of the surgery in acute cholecystitis setting is the expertise. Expertise is the key. As you have rightly mentioned that if we have a high volume center, then definitely we can proceed with in acute cholecystitis setting, even in between 7 to 14 days. But I think one should keep bailout procedures in their hand if they are dealing acute cholecystitis in after 7 days. And second topic, as you have rightly mentioned, mild biliary pancreatitis, as the consensus is that we can do that surgery. Like in our practice, we used to say a line that the patient with gallstone should go without a stone immediately within the same sitting of the hospital stay. And I think you have rightly covered the topic post ERC when to do the surgery. So, sir, I think you have covered all those three situations.
Take the comments and questions from the chat box, Vinay.
Yes. So first of all, we have coming from Dr. Shalu Gupta ma'am. In moderate pancreatitis, if CBD stone with jaundice, ERCP when indicated, sir?
Again, that's a nice question, although it's a totally different topic for discussion. ERCP, if the patient has cholangitis, that's a short indication for ERCP. And of course, if the patient has, pancreatitis and local complications already, then I think the pancreatitis management would take precedence. Yeah, it depends on a lot of things. You would obviously image the patient, see the MRCP, see the size of the stones and what is happening. So if it's very small stone, sludge, and if it is nothing, we can just wait it out. But if it is early in the course of pancreatitis and there are significant stones, then you might want to do a ERCP and at least tend the patient. Especially, I think cholangitis is the only clear-cut indication. Now there's a lot of
Sorry.
Yes, sir.
No, please carry on. Please carry on.
No, I think now there is a lot of recent evidence also. There's a recent RCT also that has been published on timing of ERCP and in pancreatitis. So, yeah.
Vinay, before this, there is a comment by Ajay and a question by Naomi. Please take that.
Sir, I'm not able to see that comment, sir.
Okay, Ajay says, yeah, I'll read it out. Dr. Ajay Sharma says high volume centers have always been discussed, but he thinks it should be corrected as high volume surgeons, as experiences only of the surgeon, especially as far as lab chole is concerned. And secondly, high volume center can have relevance as in case of problem, you can have support. Yeah, that's an important point. Naomi wants to ask if after ERC due to gallstone pancreatitis and CBD stone extraction, you found no stone in the gallbladder, would you still perform cholecystectomy? Kishore.
Yeah, that's an interesting question. I mean, you have to evaluate if the stones, if you think the stones came from the gallbladder in the first place. What I mean is, you know, if you think the stones have slipped from the gallbladder, I would still do a cholecystectomy. If you think there are stones that are primarily formed in the bile duct, like if there's some other pathology in the bile duct, like a stricture or a choledochal cyst which has led to the formation of stones, then you can see how we want to address that primary pathology. But otherwise, if the stones have slipped from the gallbladder, I think a cholecystectomy should be done, because it will again form. I mean, once the gallbladder has formed stones, it's likely to form stones again.
Oh, that's what London Max said.
Yeah, Vinay, take the question from Kaushik.
Yes, sir. There is a question from Kaushik Bhattacharya. Is there a learning curve for surgeon embarking on laparoscopic cholecystectomy in acute setting? What is the definition of surgical expertise and qualification to be designated as an experienced surgeon before she take on acute cholecystitis cases for lap chole? Kishore?
Yeah, there is definitely a learning curve. So that part of the question is very clear. But in terms of volumes and metrics, I don't think there is any agreed standards, nor are there formal accreditation bodies which can say that you have done so many, so you're experienced to do acute lap choles for acute cholecystitis. So I mean that you have to take an individual decision. If you think it is difficult for you, it's difficult for you. So you shouldn't take it on and not cause a problem. So I don't know if there's an exact number. There are numbers which say, I mean, there are, studies which say that bile duct injuries can occur by experienced surgeons also. So it's not just the numbers. It's just that if you can do it safely, I mean, you should do it. But that decision you have to take. So I don't think there is any formal way to, define this. So I don't know. I can hear from Sadiq sir or Professor Kapoor to see if there's any way to define this.
We have another question from Jayanta Bhaumik. For a documented CBD stone, what is better, pre-op ERCP or a post-op ERCP if CBD surgery expertise is not available?
Practically speaking, a pre-op ERCP would be better because that is conventional and that is what is normally done. The reason for that is, suppose the ERCP fails and you're doing surgery, you always have the option of doing a surgical clearance, with a lap CBD exploration or a open surgery if you can't do it laparoscopically. But if a post-operative ERCP, then if the ERCP fails, then you have to fall back on surgery again and you have to go back in. So only from that point of view, I would think that a pre-op ERCP is sensible.
Yeah, quick answers to some remaining questions, please.
Yes, sir. There is another question from George G. Torres. Do you consider some indication for open in difficult acute cholecystitis conditions?
Again, it depends on the expertise that is available. If you have sufficient expertise and if you can adopt various bailout strategies, which are clear-cut and well-defined. Again, it's a long sort of talk by itself. You can do most of the acute cholecystectomy. But intraoperatively, if you find that it is difficult and you cannot proceed, it is always safer to open and do the surgery. So that decision sometimes has to be taken intraoperatively. Most of the time, it has to be taken intraoperatively. But this is again a personal sort of thing. It's different for different people. Different surgeons have different levels of experience. So whatever is your experience, the end point should be, it should be clear that you have to remove the gallbladder, save the bile duct, and do a safe surgery. So if you can do it laparoscopically, well and good. If you think it is difficult, it's better to do it open. If you think it's too difficult, you can back out also. So,
we have last question, sir, from Abdullah Mamoon. Patient admitted with recurrent gallstone pancreatitis, and patient is settled, but his altered liver functions are there, and lipase level are 2600. Can we do the lab poly now, or should we wait for the to drop down the lipase?
see, I mean, there is no rationale of doing serial amylase or lipase to monitor the pancreatitis. That's the first thing. And earlier, I think there were some papers actually on this which looked at serial lipases as the serial amylase values before saying that the pancreatitis has settled and going in for surgery. I think that is a sort of outdated concept. This was there in Annals of Surgery. There's a paper actually in Annals of Surgery which looks at falling amylase levels as a criteria for deciding that the pancreatitis has settled before going for lap cholecystectomy. But this was in the late 90s or early 2000s. But I think nowadays we don't really follow that. We don't look at serial values of amylase lipase to see if the pancreatitis has settled. If the patient has settled clinically and the imaging wise also there's no large collections or necrosis, so that would be a good time to do the lap cholecystectomy.
So there is a last another question. Should MRCP or ERCP be done in every case of gallstone pancreatitis?
No, the short answer is no.
Okay. I think we have covered all those questions which have been there in the chat box. Kapoor sir.
Okay, thank you, Kishore, thank you, Vinay. And with that, if any,
Dr. Kapoor, can
yes,
I
Sadiq, please
just make one comment that
yes.
I must always say this, that Kishore has the special art to make literature and evidence more readable and understandable, and that's why I love his presentations all the time. So thank you very much. And I just want to address this point which was raised about experience and how you should do it. I think the first and most important thing is to develop graded expertise. So you start doing in early in grade 1, then progress on to grade 2, and then go along in terms of the timing, in terms of how far you can go to do an acute cholecystectomy. And the experience you can gain if you have a center with people who are doing these things at various points. And in that sense, the center experience is also important because you watch people do it and you gain expertise and understand how to deal with this situation. So a combination of these two things would get you to the level that all kinds of acute cholecystitis you can do. That's from my side. Thank you very much.
So Dr. Jorge Torres is one of the senior HPB surgeons from Brazil. Thank you, Dr. Torres, for joining. I've been putting this small note in the chat box that those who are still not members of Jaipur Surgical Tutorial, please send a WhatsApp message to Dr. Anand Nagar, my colleague who's been coordinating JST activities for last more than 2 years. We now move on to the last presentation of today, which is by Dr. Vishal Gupta, who again is a safe cholecystectomist, if I say so. He has a great interest in cholecystectomy and making it safe, like Sadiq and Ibrar. And to chair this session is none other than Dr. Anand Nagar, who's the key person behind this online education portal, which is Jaipur Surgical Tutorial. Over to you, Anand. Anand?
Good evening, sir. I would like to invite Dr. Vishal Gupta. Dr. Vishal Gupta is currently head of department at Surgical Gastroenterology, AIIMS Bhopal. Formerly, he was a past professor of KGMC Lucknow. He published many articles, and he also sent many videos on the YouTube regarding the safe lap cholecystectomy. He also published a book with Kapoor sir for the regarding safe cholecystectomy. So over to you, sir, for this presentation.
Before Vishal starts, I also have to add that in my professional will, I have written that Vishal will inherit my book on safe cholecystectomy. Vishal.
Good evening, sir. Am I audible, sir?
Yes, sir.
Yeah, good evening, everyone. And I would like to thank Dr. Kapoor, sir, and Dr. Sikora, sir, for the kind invitation and for this lecture. And this topic is a bit unusual and unlike many other topics being presented in this masterclass. So I would be covering the checklist and culture of cholecystectomy with reference to safe cholecystectomy. So what is the checklist? So if you go by the definition, it is the list of action items, tasks, or behaviors arranged in a consistent manner, which allows the evaluator to record the presence or absence of the individual listed items. So this is by definition. So if you go by the definition, we all use some kind of informal checklist in our day-to-day routine life. But if we talk about the formal checklist, the genesis of formal checklist lies in the accident of 4-engine aircraft bomber of the US military in 1935. Actually, that was the catalyst to develop the safety checklist in the aviation industry. And after almost 70 years of that incident, the checklist was introduced in the medical science when the John Hopkins checklist for prevention of central sepsis was introduced in 2004, and subsequently WHO surgical safety checklist were introduced in 2009. So this was the John Hopkins 5-item central safety checklist. It was a very basic checklist involving very basic components like washing your hands to placing a sterile dressing over the catheter. And then we have a surgical safety checklist composing of 19 items. And you have to check the list before induction of anesthesia, before skin incision, and before closing or shifting the patient. And I will not go into the detail of this surgical WHO surgical safety checklist. So are these checklists are beneficial in our healthcare delivery? Definitely they are, yes, because by evidence, it was shown that when the John Hopkins safety checklist was introduced, the centralized sepsis dropped down to 0 from 11%. And after the introduction of WHO surgical safety checklist, the post-op complication dropped down from 11% to 7%. And at present, we have multiple evidences which suggest that introduction of these safety checklists in routine healthcare delivery, they do have a positive impact on the patient outcome, despite the fact that we do not have very high level of evidence in terms of many RCTs. So why these checklists work in healthcare delivery? We know that patient care delivery system is a very complex system. It involves many critical events and it is an error-prone system. So safety in this critical environment is definitely imperative to prevent any complication. So the checklist allows error prevention. It allows facilitation of recall of information because we all tend to forget in the operation theater. Sometimes very crucial steps are forgotten because of many factors like many kind of interruption. So it facilitates recall of information regarding which procedure to perform, individual steps, their order and evaluation criteria to assess the status of patient or the condition. And it enables the clinician to identify and correct missteps where the intent to execute a task was interrupted or forgotten. So this is a common experience that we are doing a laparoscopic cholecystectomy and suddenly we get a call from a ward or emergency regarding a patient, or sometimes the staff says that this particular instrument is not available or some other problem has occurred. So suddenly our mind are disrupted. We look at some other problem, we try to sort out that other problem, then coming back to the original procedure, then again we are lost what we were doing. So these safety checklists, they help us to go back to the original procedure in a better way. And they also, this checklist also standardize the treatment because they minimize the variability or inconsistency, especially if these checklists are based on evidence. So with reference to safe cholecystectomy, the checklists have been introduced, they have been assessed primarily for the intraoperative procedure checklist and they have been found to be quite useful. Like in one study by Connor, they have introduced the intraoperative procedural checklist, and they concluded that lab coli specific checklist has the potential to lower the prevalence of bile duct injury. Similarly, in 2012, a 10-step intraoperative checklist was introduced, and the authors also concluded that introduction of this 10-step intraoperative safety checklist can reduce the conversion from laparoscopic to open cholecystectomy. And this is the pre-operative preparative checklist that I have been using for quite some time. And this checklist basically, the basis of getting this pre-operative preparatory checklist was the fact that these lab coli patients in a super specialty department, they are a sort of neglected patient. They remain worked up in the OPD basis. They are admitted at the very last moment, one day prior to surgery. And when you have other major cases listed in the OT, so these patients sometimes get neglected. So to avoid any error in pre-operative preparation, I prepared this checklist sometimes back, and it consists of many factors from pre-operative indication, like it may be a simple colic or cholecystitis or pancreatitis with much more details regarding each indication. And then you can have investigation like LFT, and there are clear-cut LFT or ultrasound, any viral markers like that. And then there are a clear-cut instruction for the resident that if there is any abnormality, they have to note it, and then they have to inform their superior. And with regards to the timing of investigation, as was discussed in the first lecture, there is a clear-cut, although this may not be evidence-based, but it is very clearly mentioned that you have to inform the senior if ultrasound is more than 4 weeks old or there is any abnormality besides the presence of gallstones. So again, re-emphasizing the point that on the ultrasound, you don't have to just have a horse vision and look for the gallstones. You have to look for many other things which may be relevant for the cholecystectomy procedure, especially the some other findings like underlying cirrhosis or portal hypertension. So this is the pre-operative preparatory checklist that we have been using. And then you have a intraoperative procedural checklist, which consists of many steps, like one introduced by Connor et al., described in 2014. So along with the WHO surgical safety checklist, when that surgical safety checklist is over, pre-incision, then you have to review the liver function test, imaging, and you have to confirm whether the gallbladder is likely to be contracted. In that terms, you have to predict some kind of intraoperative difficulty. Then pre-dissection, again, these are the important points like direction of retraction, exposure of the hepatocystic triangle, assessment of the important anatomical landmarks like Rovia sulcus, and many other things. And if you are doing the intraoperative cholangiography, there are different checkpoints for the intraoperative cholangiogram as well. So these are the important points which can be very useful for the trainees as well as the young practicing surgeon. And this is the another specific stepwise checklist that can be utilized. Like once you create the pneumoperitoneum, you place the ports, you ensure the correct patient positioning, you expose the gallbladder, assess the anatomical landmarks, what we call as the B-safe landmarks. You dissect in the hepatocystic triangle, you see whether CVS has been achieved. If it has not been achieved, then you suspect some difficulty. You again reorient yourself with the anatomical landmarks, ensure proper retraction, second opinion, and get help of intraoperative imaging, and again try to reattempt to achieve the CVS. And again, if it is possible to achieve the CVS, then you go ahead with the division of the cystic duct and cystic artery. Before that, you reconfirm that CVS has been achieved with your assistant. In case of failure to achieve the CVS, then you go for the bailout study. So these are the example of intraoperative procedural checklist that may be useful for the residents or all the surgeons so that important steps are not missed. So coming to the second part of my talk regarding the culture of safety in cholecystectomy. So what is the safe cholecystectomy? It should be safe for both the patient and for the operating surgeon. So there should not be any complication in terms of bile duct injury or any other injury, and the scope for the litigation should be minimal or it should be absent. And safe cholecystectomy, basically, it is the safe practice of cholecystectomy, which starts from the first contact with the patient, then goes with the next step of surgery, then discharge, and even with the follow-up, because some of these patients can develop complication of bile duct injury even after the discharge. So that becomes very important. So the maximum safety of safe practice involves both technical skills of actual procedural execution of the procedure of cholecystectomy, as well as the certain non-technical aspect which covers before surgery, that includes preoperative assessment of workup and the postoperative care. So both these technical and non-technical aspects, they actually makes the safe practice of cholecystectomy. And this culture of safety in cholecystectomy or COSIC was basically introduced by Professor Strasberg in 2013, and subsequently the SAGES Society that adopted this safe cholecystectomy program. And there are multiple components, and they have described 6 strategies to minimize the risk of bile duct injury as a part of this culture of safety in cholecystectomy. The most important being the critical view of safety as a target identification of the cystic duct and cystic artery. Then to understand the potential for aberrant anatomy in all the cases. I will just briefly cover all these points later on. Then liberal use of intraoperative imaging for biliary tree, cholangiogram or some other imaging. Then the concept of timeout before you clip or divide any structure. And then you have to recognize when the dissection is actually approaching the zone of significant risk. Then you have to preempt this danger. You have to stop the dissection before you enter into the problem. And then you have to opt for bailout or salvage strategy to complete the procedure safely. It is not necessary to complete the cholecystectomy in terms of complete removal of the gallbladder. In all the cases, what is more important than removing the 100% of the gallbladder is the safe completion of the procedure to prevent any post-op injury. And one other most important component of this safe culture is getting help from another surgeon whenever there is some difficulty or some doubt is there. And some of these strategies are technical, some are non-technical, and mind you, non-technical components, they always remain underestimated, and most of the people, they are not aware of these things. So coming to the critical view of safety, I will not go into the detail. It consists of 3 components, and all the 3 components must be there to call it as a CVS, and it should be confirmed by the doublet view, anterior and posterior view. And there is enough evidence that to suggest that the critical view of safety remains the most reliable target identification method, and it can provide 100% protection from the misidentification injury. Mind you, it is the misidentification injury. It does not prevent against the technique-related injury when the surgeon is not experienced or there is a injudicious use of energy sources during the cholecystectomy. And this CVS has been uniformly recommended by almost all societies for the prevention of bile duct injury. And then you have to understand that there is always a potential for aberrant anatomy. What we read in the textbook as a classical anatomy, like has been mentioned in this picture, is present in only about 50% of the cases. And in remaining 50% of the cases, so every alternate case, there is a potential for many kind of variation, although all not variations are important in terms of bile duct injury, but there are certain anatomical aberration like the aberrant insertion of the right sectional duct or the cystic duct joining the aberrant sectional duct. They are more prone to have a bile duct injury during the procedure. Similarly, we can have many variation in the cystic artery, as has been mentioned by Dr. Ibrahimullah. I will not go into the detail, but always you have to look for this aberration, and because you divide the cystic artery close to the gallbladder, sometimes they may not be that relevant. And sometimes this normal anatomy get altered because of the underlying pathology, maybe because of local recurrent inflammation or the Mirizi syndrome. So there is always a potential of having the aberrant anatomy. And these are the fixed anatomical landmarks already mentioned earlier. You have bile duct, rubia sulcus, hepatic artery, umbilical fissure, enteric structures, and R4U line. And you have a mnemonic like be safe for the resident. They can easily remember these anatomical landmarks with this mnemonic of be safe. And you can have an R4U line. 2 minutes, just finishing, sir. Yes. So you can have important these landmarks for assessment of safe or unsafe zone. I will not go into the detail. And you have to have a adequate and proper retraction, because in case of inadequate retraction, there is a potential that CVT may be tented, and then you can go across the CVT instead of cystic duct during the dissection. So this is the right direction, fundus toward the right shoulder and infundibulum towards the right lower quadrant or left upper shoulder. And exposure can be facilitated by certain helpful maneuvers. You can decompress the gallbladder, you can put additional port, or you can take a suture in thick wall gallbladder for proper detection. The important another component of safe cholecystectomy culture is the timeout. Basically, it is a momentary pause, both procedural as well as the mental. You stop for a while, you reassess the situation, and then act accordingly. So there may be certain clues where we suggest that you should stop. So there may be certain findings like severe fibrosis or impacted stone, dense adhesions, fibrosis, or the operative time is increasing. Certain other stopping rules are there, especially if this large artery pulsation behind the presumed cystic duct or this medium large cliff fails to occlude the ductal lumen like that. So these are the certain intraoperative pictures or intraoperative findings that suggest you that you should reassess, then act, and if need be, you should seek help. Don't just go ahead with the completion of the procedure. And seeking help is definitely useful. In case of doubt, difficulty, a simple advice from a member of surgical team other than the operator will be useful, as has been shown by the literature. Thus, in around 1/5 of the cases, misidentification can be revealed by simple advice. And another, this in-vicinity cholecystography, as this term introduced by Kapoor sir, this is very useful. You always take help of another surgeon or colleague who is not versed. So that help is very helpful actually. So this is the component pre-operative, operative, and post-operative care. They are the essential component of the safe cholecystectomy concept. And just to summarize that checklist, they are the useful adjunct to safe cholecystectomy. And as mentioned by Gawande, that we all make errors regardless of experience and competency, and use of checklist is not a sign of the absence of skill, but it is a sign of a rational strategy for fulfilling the oath that a first do not are. And with regards to culture of safety in cholecystectomy, it is a new culture of safe practice of cholecystectomy. Practicing surgeons and trainees should be aware of this culture. They should strive to adopt it and imbibe it in their routine practice for a safe surgical practice. Initially, it may seem to be difficult, but with persistent and diligent effort, they can easily adopt it in their routine practice. Thank you.
Anand, thank you, Vishal, for showing this book. So as I have been putting in the chat, all those who have asked questions, please send me a mail, write your complete postal address. You will receive a complimentary copy. Yeah, Anand, please carry on.
Yes, sir. Thank you, sir. Thank you, Vishal, sir, for such a nice and elaborative session. In your presentation, we get to know the checklist you are using. We should all use this checklist, as you told that we all surgeons are very busy. We plan the surgery or we admit the patient just before day before surgery. So the checklist you are using, we should all use this checklist. And I get to know so many new things regarding checklist. As we know, the checklist we are using as WHO surgical safety checklist. So see. We should use the checklist you are using in your practice. We should all use this. In between, I missed because of network issues.
Yeah, I think Dr. Sadiq has devised a checklist which he displays in his theater. I would request Dr. Sadiq to put it on, send it to Anand. Anand can then add it to the JST portal. And Vishal, if you have a checklist which you have, you are using, please do the same. Anand, take some questions and comments from the chat, please.
Yes, sir. One of the questions which was asked by Dr. Rajesh, which is a question of previously told by Dr. Ikrar sir. What is the incidence of absent rubeal sulcus? So many times it seems to be absent or not to be so prominent.
Vishal or Ibrar, anyone can take.
Sir, in literature, around 75 to 80% of the time, you will see rubeal sulcus, although it may vary in its morphology. Around 15 to 20% of the time, rubeal sulcus is apparently absent.
Yeah, there is a question from Dr. Monica also.
Yes, sir. Dr. Monica asked regarding any special pre-op checklist for the patient with cirrhosis and acute cholecystitis.
No, I think these are the very specific situation. So you have acute cholecystitis, you have cirrhosis. So I think with these two key situation, I don't think there is any other specific checklist. But in general, you can have a checklist by which you can assess that this patient is having cirrhosis with acute cholecystitis. So you have to be more cautious in terms of your preparation or preparation for the in the preoperative period as well as during the surgery.
Yes, and some of the doctors ask for the checklist, so we'll share. Kapoor sir, will give checklist with our group JST or whatever. Say they are asking your email ID also.
Yes. Sadiq, anything you want to add?
No, I mean, nothing to add, but just to re-emphasize the fact that this is not a simple operation. It also needs preparation. And as Vishal has pointed out, that the more better prepared you are, you would be able to do a safe cholecystectomy and actually save a bile duct. I mean, I don't consider it as removing the gallbladder, but it's like saving one more bile duct. That's how I will put it. And I think this mindset has to be of going stepwise, pre-op, intra-op, and post-op, as Vishal has shown, that you need to pay specific attention to all the steps in order to get through the cholecystectomy safely. And as we always say, that there are various ways of doing. Each group adopts various ways. Like, for example, amongst the various things, what we have done is we always post our CVS on the WhatsApp group of the department, and somebody sees that, and if there is a problem amongst the consultant that somebody has a doubt, a red flag is raised. And what we have observed, that with that, the ability to demonstrate a CVS has gone up because we are in the process of documenting it. And once you get into that process, you tend to do things in a more organized manner. So that's the whole thing about culture of cholecystectomy and the checklist.
Some people are asking on the chat how to join JST. I have been putting that notice. Please send a WhatsApp message to Dr. Anand Nagar. I'll put his number again. And as far as the book is concerned, I have put the link of the soft copy, but that is of the first edition, which was a very primitive one. The second edition, the one which Dr. Vishal has displayed, those who send me their complete postal address will receive a complimentary copy over a period of time. At least those in India. For abroad, I'll have to check whether it will be possible for me to send. I think it is 8:59. We have one more minute. So Ibrar, any last minute comment? Ibrar, please unmute yourself.
Yeah. No, I think it's all very well covered. I don't have any.
Okay, so for the last time.
Can I say one thing, sir?
Yes, please.
I think in the present era, if we see the training in surgery, it is more and more focused on the technical aspect. And somehow the current training is lacking in the teaching the philosophy of surgery as a whole. And when we talk about the safe cholecystectomy culture, so that safe cholecystectomy culture actually also apply to all other surgical procedure. So I personally feel that the residents should also look beyond the technical skill part of the training, and they should also go beyond the technical aspect in terms of certain other non-technical points that I have mentioned. So one of the part is the pre-operative preparation, and somehow that part is lacking in training or education in surgery as such. And second, I just recommend this checklist manifesto. It is a very beautiful book, and whoever is interested in this checklist part, they would love to read the concept how the checklist actually evolved over a period of time from the non-medical to medical area.
Okay, I think we started in time. We should finish in time also. Ajay says that message from this session is Dr. Sadik's statement. I think I need to read it again. Not that we have removed one gallbladder. It is important that we have saved one more bile duct. I think that's very, very important. The aim of, or the ultimate end result of cholecystectomy should be that not only the gallbladder is removed, the bile duct is saved. And second part is probably more important. So I think we close today's session. Thank you all the speakers. Thank you the chairpersons. Thank you all the delegates, including people from abroad. I forgot to mention Dr. Paleshwan Lakhi Joshi, who's one of the senior GI surgeons from Nepal. She'll be joining us again tomorrow as a faculty. And there are so many other colleagues from abroad. And thank you, Sadik, for suggesting this topic for the second masterclass. I will also announce that the next month, last Thursday and Friday, the topic will be chronic pancreatitis. We will be sending and posting the details to everyone. So we meet tomorrow again at 7 p.m. Good night.